Good evening, everyone. I hope I'm audible and visible. So please confirm in the chat box once so that I can just get this lecture started. 11 and yeah, fine. Fine, thank you so much. Good evening, everyone. Samantha is also here. Fine, thank you. I hope I'm audible and visible. Let's begin today. So today's lecture for dermatology, I am Dr. Jazeer, the dermatology faculty at PW MedEd. And today in this Farre series, this is the second lecture that we are having today. And we will be basically discussing about some of the diseases in the sexually transmitted infections. Also leprosy, which is obviously a very, very important topic in dermatology. And some of the vesiculobullous disorders as well. Okay. So these are the topics that I'm planning for the day: STI, leprosy, and vesiculobullous disorders. So in the last discussion itself, we had discussed about what should be our methodology when we are going to give a subjective kind of an exam, right? So here we will definitely have to follow the same rules like whatever I have discussed in the last time. Like always begin your answers with a definition wherever possible, right? That is the first thing. And then after giving a proper definition, we will have to start with whatever is asked in the context, okay, the actual context of the answer. Like for example, if describe the etiology, then you start with the etiology. Describe the clinical features, then you start with the clinical features. And then it is always better if you give a conclusion statement as well. So we'll see one by one. So we will definitely start with the first topic, that is sexually transmitted infections. Bhumi Sinha, very good evening. Yep. So now let's see the first question of the day. Enumerate the causes of genital ulcer disease. So just imagine that this has come like a short answer question where you are asked to list the causes of genital ulcer disease. Now, how do you want to begin this answer? How do you want to enumerate the causes? See, whenever you get this kind of a question, please first, as I told you, definitely give a short definition. अब इसमें कौन सा definition देंगे? यहाँ पे the topic is genital ulcer disease, right? So let us give a small definition for a genital ulcer. Jai Kumar says HPV, human papilloma virus. Let's see, but before that, let me just write down the definition first. So in the definition, what we will write is, we will write down about genital ulcer disease. है ना? So what is a genital ulcer disease? It refers to the presence of what? One or more ulcerative lesions, right? Which involves the genitalia. Presence of one or more ulcerative lesions in the genitalia. Isn't it? So this is what we can give as a very short definition. And we can also add on one more thing: mostly caused by sexually transmitted infections. So isn't it a very simple definition? Like, what is a genital ulcer disease? It is a condition where you may find one or more ulcers in the genitalia, mostly caused by sexually transmitted infections, right? Now, we'll talk about those facial acne sometime. Okay, let us continue with this list. Now, what we are going to do is, we have to enumerate, right? So, enumerate is a question. So, when you enumerate, you can just write down that there are two types, or there will be two causes. There can be due to STI causes or due to non-STI causes. So STI means sexually transmitted infections, which means ulcer can happen because of either sexually transmitted infection or a non-sexually transmitted infection. Now, can anybody tell me very quickly in the chat box, what are the causes of sexually transmitted infections which can cause a genital ulcer disease? Which can cause a genital ulcer disease. I'll just give you few seconds for you to answer it in the chat box. So if you're not able to recollect, then I will just let you know what are those causes. Can you just give it a try? No problem if it goes wrong as well. Just give it a try. See, human papilloma virus usually causes warts. It usually does not cause ulcers. So that may not be a correct answer. But Kalaivanan says HSV2. Very good. HSV2, yes. Syphilis, yes. Syphilis, trachomatis, all those answers I can see in the chat box. Excellent. It's a very good try. So first what I will do is, I will just write down the causes. One is syphilis, as you have mentioned. Very good. So another one is LGV, which means lymphogranuloma venerum. And then we have donovanosis. We also have herpes genitalis. And the last one would be, one more is going to be chancroid. So these are the sexually transmitted causes for a genital ulcer disease. You know how you can get a bonus mark here is that if you just write down the causes, in case you are able to give them a the causative organism as well, that will definitely be a bonus. So how about giving it a bracket like syphilis? What is the causative of syphilis? Treponema pallidum. So this is a bonus. And how about lymphogranuloma venerum? Any idea what is the causes? That is the reason why I guess Samantha was answering trachomatis, right? So यहाँ पे the cause will be, yeah, chlamydia trachomatis. So this is chlamydia trachomatis is another cause. How about donovanosis? So donovanosis, which was previously called as granuloma inguinale, it is caused by Klebsiella, isn't it? Klebsiella granulomatis. So this is the causative for donovanosis. Herpes genitalis, I guess Kalaivanan had answered earlier. Herpes genitalis is usually caused by HSV2. Herpes simplex virus 2. And what about chancroid? Anyone? Chancroid? Chancroid is caused by Haemophilus ducreyi. I couldn't see this answer in the chat box yet. So this is caused by Haemophilus ducreyi. So these are the various sexually transmitted infections which can cause a genital ulcer disease. Now comes one more thing, that when we enumerate the causes, you definitely can also mention the non-sexually transmitted infections which can be a cause. Now this can be something like a bonus because everybody will remember sexually transmitted infections. What are the non-STI causes? One may be fixed drug eruption. It can be due to a fixed drug eruption, which is considered to be a drug eruption, right? Another disease where you get recurrent aphthous ulcer, genital ulcer, and anterior uveitis. Now, any idea what am I talking about? There is a recurrent ulcer in the genitalia. There's a recurrent ulcer in the oral cavity, like aphthous ulcer, as well as some eye symptoms like anterior uveitis. What is that? Yeah. So this one should be Behçet's disease. This one should be Behçet's disease. And sometimes it can be due to carcinoma as well. So these are some of the causes, sexually transmitted and non-sexually transmitted causes of genital ulcer disease. Ho gaya, right? Because all these points are carrying, all these points will be carrying additional marks, right? That is all about this short question. So now let's see another question where we are asked to differentiate between a primary syphilis and a chancroid. Now, how do we differentiate primary syphilis with chancroid? Now, before we start, it is better whenever you get something like this, okay, like a comparison, it is better to go for a table, right? Making a clean table in the answer sheet and writing down the comparison, isn't it? That will be the much more easier or a better method. See, Behcet disease is going to be a disease where a patient can present to you with recurrent episodes like of aphthous ulcer in the mouth and recurrent episodes of genital ulceration. And these patients will also be having some ophthalmology manifestations like anterior uveitis and all. Okay? That is called as the Behcet disease. Drug eruption. The meaning of drug eruption. See, drug eruption means an adverse drug reaction. जैसे you take a drug and you get some side effect, है ना? So this is fixed drug eruption. That is a type of a cutaneous drug reaction. It's a type of a cutaneous drug reaction. Yes, very good, Kalevan, and HLA-B51 is an association with Behcet's disease. So now let us come back to this question about the difference between primary syphilis and chancroid. Now, how do we give a start? यहाँ पे we cannot define what is syphilis, what is chancroid, right? But together, if there is anything common, just describe them. Like primary syphilis and chancroid, isn't it, are sexually transmitted infections, usually presenting with genital ulcers, isn't it? Usually presenting with genital ulcers that differ in presentation, etiology, isn't it? That differs in presentation, etiology, and clinical course. So this is something that came to my mind when we try to describe it, isn't it? So this is what we can describe. Okay, syphilis and chancroid both are sexually transmitted infection, but they both present as genital ulcer. But these ulcers are going to be different in their presentation, in their clinical course, in their etiology, etc. So that is what we can describe for both primary syphilis and chancroid. Now let's come to the main part, because the examiner is asking you to differentiate. So when we differentiate, let us first write down in the first column, then let us write down syphilis here and chancroid in the second column, right? And first let us write down what is the cause. The first is going to be the difference in the organism. So just few minutes ago we discussed that syphilis is caused by Treponema pallidum, whereas chancroid is caused by Haemophilus ducreyi. It is caused by Haemophilus ducreyi, right? The second thing that we will discuss is the ulcer characteristics. Now, what is the characteristic of the ulcer? Remember, S4S, that is syphilis, is a silent disease, which means here the patient will have a painless ulcer. Whereas in chancroid, the patient will have a painful ulcer. So एक हो गया painless, the other one is going to be painful, right? And then let us write down about the lymphadenopathy, which means about the involvement of the lymph nodes, right, in the inguinal region. So regarding the lymph nodes, S for S, syphilis is silent, right? So in syphilis, there will be a painless lymphadenopathy. There will be a painless lymphadenopathy. Whereas in chancroid, there will be a painful lymphadenopathy, and this painful lymphadenopathy is called as buboes. They are called as buboes. That's a very, very important thing. the lymphadenopathy in Chancroid is called as Bullous. And then let us see how do we diagnose. So the diagnosis of syphilis, any idea? Is there any investigation that we can do to diagnose primary syphilis? Primary syphilis. So yeah. So here the diagnosis of primary syphilis can be done with an investigation which is called as a dark field microscopy. Dark field microscopy can be done. So when you do a dark field microscopy, what you can see here is going to be a corkscrew motility. You can see a corkscrew motility of the Treponema pallidum. That is how you can diagnose a primary syphilis. Whereas when it comes to a chancroid, what do you want to do? Zinc, not zinc. When it comes to chancroid, we can go for a gram staining, because when you do a gram staining, you can see that this bacteria, they are organized in a very peculiar pattern, because they would be organized as a railroad track pattern or school of fish pattern. Railroad track pattern or a school of fish pattern. That is how you can diagnose syphilis as well as chancroid. And the last point is, what about the treatment? In the cases of syphilis, there is something which is the drug of choice. Here, the drug of choice is benzathine penicillin, whereas chancroid can be treated with azithromycin. Whereas chancroid can be treated with azithromycin. So can you see, this is how we can differentiate primary syphilis and chancroid. And it should not be difficult for you. You will have to remember the causative organism, Treponema pallidum, or it can be Haemophilus ducreyi. But everything is opposite. Syphilis, painless ulcer, painless lymphadenopathy. Chancroid, painful ulcer, painful lymphadenopathy, right? And diagnosis is done by dark field microscopy and gram staining, and the treatment is with benzathine penicillin or azithromycin. ये हो गया आपका short answer, where each and every points are actually addressed in a very crisp and a brief method. Clear? Okay, so that is all about this question. So now let's see another question. Write a short note on secondary syphilis. Now we know that syphilis is a great imitator or a mimicker, right? So syphilis, it goes through various stages. So if you get a question regarding what about this secondary syphilis, how are you going to approach this type of a question? The first thing is, in secondary syphilis, we will have to start with, yeah, Samantha, I'm going to mention about what is the difference between primary and secondary syphilis. Okay. So in primary syphilis, kya hoga? The patient will present to you with a painless ulcer in the genitalia and a inguinal lymphadenopathy. If this patient is not treated during primary syphilis, then the patient may proceed to secondary syphilis, which means secondary syphilis is a systemic stage of syphilis, isn't it? It is going to be a systemic stage of syphilis due to hematogenous dissemination of Treponema pallidum. So what happens when the patient who is having primary syphilis is not treated? Then what happens? The Treponema pallidum, which was present in the genital ulcer, that Treponema pallidum will now disseminate in the blood. That is why when there is a hematogenous dissemination, the patient will go into a secondary syphilis. Clear? So you can also mention that this usually occurs weeks to months after primary syphilis. This usually occurs weeks to months after primary syphilis. So that is about the definition of a secondary syphilis. Now, writing the characteristics. So when you are going to write down the characteristics of secondary syphilis. Now here what you can note down is that what will happen? The patient who had inguinal lymphadenopathy in primary syphilis now becomes generalized lymphadenopathy. Generalized lymphadenopathy in secondary syphilis. So this is one difference. Okay, the primary syphilis mein there was an inguinal lymphadenopathy. It becomes a generalized lymphadenopathy in secondary syphilis. Along with this generalized lymphadenopathy, the patient will have lots of skin symptoms. Lots of skin symptoms. That is why this secondary syphilis becomes very important in dermatology. Now let us write down what are the skin symptoms in secondary syphilis. The patient will come to you with Condyloma lata. The patient will come to you with Condyloma lata. What is the meaning of Condyloma lata? It means there are some flat topped lesions in the genitalia. There will be some flat topped lesions in the genitalia. Along with Condyloma lata, the patient will have pigmented rashes in the palms and soles. The patient will also have some kind of a hair loss, alopecia. What is this alopecia called? There will be a moth-eaten alopecia. Moth-eaten alopecia shall be there. And then you can also see some lesions in the oral mucosa like mucus patches and snail track ulcers in the oral mucosa. So all these are the different findings of secondary syphilis. Okay? So what are the different findings? Generalized lymphadenopathy, Condyloma lata, pigmented rashes in the palms and soles, moth-eaten alopecia, mucus patches, and snail track ulcers. All these are going to be separate points for your exam, isn't it? And you'll be getting separate marks for each and every point. Now, if a patient goes into secondary syphilis, how do you diagnose them? So here the diagnosis of secondary syphilis is not by dark field microscopy. Remember, dark field microscopy is only for primary syphilis. Now here it is done by testing antibodies in the blood. It is by testing for the antibodies in the blood. So do you have any idea what are the investigations that we can do to diagnose secondary syphilis? What antibody testing can we do? There is a test called FTA-ABS. There is a test called TPHA, isn't it? There is a test called VDRL. All these tests can be done because these are all serological tests where we are going to detect some antibodies in the blood which can be done to diagnose syphilis. Once the diagnosis is confirmed, then you are going to treat the patient. The treatment, the drug of choice is going to be the same. It is going to be benzathine penicillin. The treatment is going to be benzathine penicillin. All the skin lesions can be present, not necessarily, Samantha. Some of the lesions can be present, but usually these are the lesions which can be seen in a patient of secondary syphilis. Clear? So usually these are the lesions which can be seen. That is about a short note about a secondary syphilis. Clear? Now let's see another question. Write a short note on Condyloma acuminata. Now what is this condyloma? Because we just now learned about Condyloma lata. This condyloma was seen in secondary syphilis. Now what about Condyloma acuminata? Anybody in the chat box, just let me know कि Condyloma acuminata क्या हो सकता है? Can you just tell me what could be a Condyloma acuminata? Yes. So this is actually caused by human papilloma virus, isn't it? HPV, isn't it? So first, let us write down a definition for Condyloma acuminata. So you always start with definition, right? So in the definition, hi Medicos vlog, very good evening. So in the definition, what we will write is Condyloma acuminata are benign. So Condyloma acuminata are benign anogenital lesions, isn't it? Which is also called as genital warts. Is also called as genital warts. That is a simple definition for a condyloma acuminata. These are benign lesions which can be seen in the anogenital area, which is also called as genital warts. And what is a causative organism? The causative organism is human papilloma virus. Now this human papilloma virus, we usually call it as HPV. Which type of HPV usually causes a condyloma acuminata? Very good medicals vlog, it is HPV. But which HPV? It is 6 and 11. It is 6 and 11. That is what you have to write down. Now, what are the risk factors because of which a patient can develop a condyloma acuminata? One risk factor is because of HPV infection, right? Another risk factor is because of multiple sexual partners. Another is going to be multiple sexual partners. And the third one can be because of early onset of sexual activity. And in some cases, one of the risk factor can be immunosuppression as well. Immunosuppression can also be one of the risk factors that is involved in the cases of human papilloma virus infection, which is called as Condyloma acuminata. Then let us write down what are the clinical features. How will a Condyloma acuminata look like? The Condyloma acuminata, this usually presents with exophytic growths in the genitalia. So what do you mean by exophytic growths? Exophytic means which grows outwards of the skin. Okay, so these are something which can grow outwards towards the skin. It is called as exophytic growths in the genitalia. And how are you going to diagnose it? So the diagnosis is usually clinical diagnosis. So when a dermatologist or a doctor would see a patient of Condyloma acuminata, he usually does not require any investigation. The moment he sees, he can make a clinical diagnosis of Condyloma acuminata. Okay. So that is how we can see this Condyloma acuminata. It's usually a clinical diagnosis, but if there is some test which can be done, like you can use few drops of acetic acid over the skin, over the genital mucosa, and wherever you can see these warts, they may show a whitening or a change in color. So we can also write as TCA application, that is trifluoroacetic acid application, this will show acetowhitening can be seen. So what happened? The genital warts may turn white in color when you apply some trichloroacetic acid. This test is called as TCA testing. And you can also do a biopsy, which is not usually required, isn't it? So since it's a benign lesion, usually biopsy is not required. But when you do a biopsy, you can actually see coilocytes. So these are vacuolated cells which can be seen in the cases of Condyloma acuminata or any of the HPV infections So that is how. And finally, you're going to write down what is the treatment of Condyloma acuminata. The treatment of Condyloma acuminata is with immunomodulators. So what are the examples of immunomodulators which is used for the management of Condyloma acuminata? The immunomodulators are podophyllins and imiquimod. Podophyllins and imiquimod. So these are the immunomodulators which can be used for the management of Condyloma acuminata. There are obviously other treatment like electrocautery, isn't it? RF ablation, etc., which can also be used, which can also be done, even a cryotherapy as well. Hi Dev, even a cryotherapy can also be done. Now, what is most important is when you're all of you are going to prepare for this final exams of yours, so just see the method how we are giving the answers. That is more important here because concepts you will definitely build by reading the textbooks and all those things, because here we are going with the definition of whatever is asked. Then we are writing what is the cause behind this disease, what are the risk factors or what is the etiology behind it, then how will the patient present to you, that is the clinical features, and how are you going to make a diagnosis of this disease, and finally how are you going to treat the patient, isn't it? How are you going to treat the patient? So that is a structure which every examiner is looking for when you're going to give a answer for a subjective kind of a paper. Clear? See, Samantha, these immunomodulators as an we don't use antiviral agents. If I ask you what are the examples of antiviral agents, maybe you will answer me like acyclovir, isn't it? So acyclovir, famciclovir, gamciclovir, oseltamivir, all those antiviral agents are not used in the management. Here we use something which may change the immunity. So these are immunomodulators. These are available as topical agents, which means like creams and all, right? So podophyllins and imiquimod. And electrocautery, it is like cauterizing the skin with electricity. RF ablation is radio frequency ablation. Cryotherapy is by freezing the skin. So all these are different procedures that can be used. I hope I'm clear. Okay. So now, after discussing all these sexually transmitted infections, let us see what are the things that we will learn in leprosy. For leprosy, to cover maximum topics or points in leprosy, let us try to deal it like a long answer question. Okay? Like describe leprosy, its classification, also about lepra reaction and its management, isn't it? So something like that. Why not antiviral use? Because it was always tried, Samantha. Antiviral agents was tried, but never got a proper response in terms of human papillomavirus infections, like warts. So easily, even for the warts that you can see in the hands or anywhere in the body, we never use an antiviral agent. Instead, we go for removing it, like electrocautery and all those procedures are done. Okay. So now coming back to leprosy, we will try to discuss everything in a short and a concise method. Okay. So what are the things that we will start with the leprosy? So let's start with the definition. Let's go in a very systematic order. What is leprosy? So leprosy, anyone? Mycobacterium leprae, thickened nerve, skin loss. Yeah, very good. Everything is correct. Not skin loss, loss of sensation, right? So let's see how do we define leprosy. Leprosy is a chronic granulomatous infectious disease, isn't it? So leprosy is a very chronic granulomatous infectious disease which is caused by, as Samantha was answering, it is caused by Mycobacterium leprae, which is caused by Mycobacterium leprae and primarily affecting the skin and peripheral nerves. The skin and the peripheral nerves, isn't it? And leading to sensory loss, isn't it? And nerve deformities. So this is how we can generally describe about leprosy. It's a chronic infection, granulomatous disease, and caused by which organism? Mycobacterium leprae. Usually affects the skin and the peripheral nerves, because of which when there is a involvement of the skin, there may be a sensory loss, and when there is nerve involvement, there is a nerve thickening or nerve deformity. That is how we can describe it. Now, after describing about leprosy, then you definitely need to write down what are the cardinal signs in leprosy. There are one, two, and three. Three cardinal signs in leprosy, because diagnosis of leprosy is by presence of one of the cardinal signs. Any one of these signs is important to reach out to a diagnosis of leprosy. So let us write down what is the first cardinal sign. Do anybody know what is the first cardinal sign? The first cardinal sign is that there will be a hypopigmented or a erythematous patch or plaque lesion. So there will be a hypopigmented lesion or a erythematous lesion, like a patch or a plaque lesion with sensory loss. With sensory loss. That is the first point. Okay, hypopigmented patch with sensory loss, erythematous plaque with sensory loss. That becomes the first point. The second point is going to be a thickened peripheral nerve. Okay, so there is going to be a thickened peripheral nerve with a sensory or a motor impairment. With a sensory or a motor impairment. That is the second point. And the third point here is, yeah, ulnar nerve thickening and all comes under this one. Very good. And the third point is about one of the investigation, where you can the demonstration of acid fast bacilli, acid fast bacilli in a skin slit smear. Okay, in a skin or a slit skin smear or a skin slit smear, isn't it, which is called as SSS. So these are the three very important points. So please remember, this will definitely fetch you marks. So here three cardinal features, out of which at least one is present, the diagnosis is going to be confirmed. Now, what are the three cardinal features? Hypopigmented patch with sensory loss. The second one can be involvement of a peripheral nerve. And the third one is demonstration of acid-fast bacilli, that is Mycobacterium leprae in a skin slit smear. So these are the three important points. And then we will write down what is about a Ridley-Jopling classification, because this is the clinical classification of leprosy. So this is the clinical classification of leprosy. So what happens in this clinical classification of leprosy is that here we divide leprosy into a spectrum of disease, based on the immunity of the patient. And when you are going to write down regarding the spectrum of the disease, yeah, very good. Lepromatous leprosy, tuberculoid leprosy, and all those things. That is very correct. So here, what we have to write down is, what is this Ridley-Jopling classification? So here we divide it into TT, BT, BB, BL, LL. So these are the five different types of leprosy based on the spectrum. So what do you mean by TT? TT means tuberculoid type of leprosy. What about BT? BT is borderline tuberculoid. And what about BB? It is borderline. BL is borderline lepromatous. And the last one is lepromatous leprosy. So these are all the different types of leprosy. Okay, TT, BT, BB, BL, LL. Yes, we are trying to cover all the important topics, because in the last Farre class we covered 3 or 4 topics. Today also we are covering 3 or 4 topics. Okay? Caliber. So this is how a spectrum of disease is. And here please mark one very important thing in red, because the best cell mediated immunity will always have tuberculoid type of leprosy, and the worst cell mediated immunity will always have lepromatous type of leprosy. That is why I have mentioned very clearly that this classification is based on the immunity of the patient. It is based on the immunity of the patient. Now, let us very quickly write down the clinical types once again. See what happens in all these clinical types of leprosy. That is, in tuberculoid type of leprosy, the patient will present to you with a saucer right way up appearance. Okay, like all of you know the cup and the saucer, right? So the skin lesion will look like a saucer right way up appearance, along with 1 to 3 lesions only. That is how a patient will present to you with a tuberculoid type of leprosy. Whereas in a patient who is having a borderline tuberculoid type of leprosy, there will be two features. One is satellite lesions, and the other one is called as pseudopodia. Satellite lesions and pseudopodia can be seen. In BB type of leprosy, it looks exactly opposite than a TT. In TT, it was saucer right way up appearance, right? So in BB, what happens? It becomes like this. That is inverted saucer appearance. There will be an inverted saucer appearance, which in some textbooks it is compared to a Swiss cheese appearance. Swiss cheese appearance can be seen. Fine. And then we have the borderline lepromatous type of leprosy, where the lesions, they almost become symmetrical. They almost become symmetrical. And the last one is lepromatous type of leprosy. In lepromatous type of leprosy, you need to write down that the patient will develop nodules in the face along with hypopigmented symmetrical lesions in the trunk, along with hypopigmented symmetrical lesions in the trunk. And any idea, anyone in the chat box, what do you call for the peculiar face in lepromatous type of leprosy? Does it look like a monkey? Does it look like an old man? Does it look like lion or something else? Any idea? So here there is a peculiar name for the face, which is called as leonine facies, right? Which is also called as the lion-like face. Is also called as the lion-like face. That is how you can see a lepromatous type of leprosy. Yeah, very good. Caliber, Samantha, all of you are answering it. Excellent. Medico's blog is also answering. Very good. So these are the various presentations in different types of Ridley-Jopling classification. Clear? And then we will also see uh, about lepra reaction, which was also asked. But before that, let us also write down what about the management of leprosy. So the management of leprosy is with multi-drug therapy, right? And can you enumerate what are the drugs that is used in the management of leprosy? It is with dapsone, rifampicin, and clofazimine. Dapsone, rifampicin, clofazimine. These are the three drugs that is used for the management of leprosy. Yeah, very good. So now let us see what is lepra reaction, because in our question, the question that was asked was describe the leprosy with its classification, which we have already done. And now the second part of the question says, what about lepra reactions? So when we are going to write about lepra reaction, so there are two types of lepra reaction. And the first point that you can mention is lepra reaction is not a drug reaction. Okay, it is not a drug reaction. And this is usually seen after the patient starts on MDT, that is multi-drug therapy. Okay, so once a patient will start on multi-drug therapy like dapsone, rifampicin, and clofazimine, then the patient may show you some kind of a reaction, which is called as lepra reaction. But remember, it is not a drug reaction. And to write down about lepra reaction, the best way is to use a table, because there is a type 1 reaction as well as type 2 reaction. So just whenever there is a chance to compare, let us always compare it using tables. So here please write down type 1 reaction, and here you can write down type 2 reaction. This type 1 reaction is also called as reversal reaction, and type 2 reaction is also called as erythema nodosum leprosum. Erythema nodosum, leprosum. Now, it's a very, very important table. So let's see how do we differentiate, and it is easy to remember. It's just a one-time read. You know why? The reason is, let's see one by one. If you're talking about what is the immunological or the hypersensitivity reaction that causes lepra reaction, type 1 is caused due to type 4 hypersensitivity, and type 2 lepra reaction is due to type 3 hypersensitivity reaction. And how can you remember it easily? Just remember the rule of 5. 1 plus 4 equals to 5 and 2 plus 3 equals to 5. So type 1 is type 4 and type 2 is type 3 hypersensitivity. Isn't it? 1 plus 4, 2 plus 3. That is one way how you can remember. The second thing is, what are the types of patient who will show this lepra reaction? Now this is also easy to remember. Every borderline type will show type 1. Now what are the borderline types? We learned borderline tuberculoid, borderline and borderline lepromatous. All these types will show a type 1 lepra reaction, whereas every lepromatous type is going to show a type 2 lepra reaction. What are the lepromatous types? That is borderline lepromatous and lepromatous type of leprosy. Easy, right? एक में हो गया borderline type, दूसरे में हो गया lepromatous type. Now, the next one is, what are the clinical features of a type 1 reaction or a type 2 reaction? Type 1 lepra reaction presents with inflammation of the existing skin lesions. It presents with the inflammation of existing skin lesion. Whereas type 2 lepra reaction, there is no change in existing lesion, but presents with fever along with nodules in the skin. Fever along with nodules in the skin. That is why we call it as erythema nodosum, leprosum. Like, because it presents with nodules in the skin. Okay, that is how a patient will present to you with a type 2 lepra reaction. And finally, coming to the treatment, in both type 1 and type 2, the treatment is going to be continue multi-drug therapy and start on prednisolone. So what is prednisolone? It's a systemic steroid, right? So that is going to be the treatment of a lepra reaction. Is that clear? So when you get a question on lepra reaction, it is better you just draw a beautiful table. In the table, you can just note down 3 or 4 features. One is about the difference of hypersensitivity. The second is about the types of patient who will show the lepra reaction. The third one is the basic difference in the clinical features. And the fourth one obviously should be regarding the management. That is to continue the multi-drug therapy and start the patient on prednisolone. Clear? That is about the treatment part of lepra reactions. So now let us also discuss about some of the vesiculobullous disorders as well. Isn't it? When a patient will present to you with vesicles or bullous lesions in the skin. Now, what is the question? Classify vesiculobullous disorders and describe Pemphigus vulgaris. That is the question now. Now, how do we start? First, let us write down what is the definition of a vesiculobullous disorder, right? So again, we are going to just make our own definition based of a logical definition of a vesiculobullous disease. So vesiculobullous disorders are a group of diseases, isn't it? There are a group of diseases which is characterized by the formation of vesicles or bullous lesions over the skin, isn't it? Vesicles or bullous lesions over the skin. Due to, why do these patients they develop a vesicle or a vesicle or a bulla? That is because of the cleavage that happens, isn't it? Due to the cleavage at the level of epidermis or subepidermis. See, subepidermis means below the epidermis. Okay, below the epidermis. So that is about the definition of a vesiculobullous disease. Clear? Now, what is the classification? So, classification here, again, it is easy. There should be either a vesicle which forms at the level of the epidermis, or there is a or a cleavage that happens at the level below the epidermis, isn't it? That is why the classification is of two types. The first classification is intraepidermal blistering diseases, and the second one is subepidermal blistering diseases. So these are the two types of blistering disease, either when the cleavage is in the epidermis or when the cleavage is below the epidermis. Can anybody tell me what are the examples of intraepidermal blistering disease? The intraepidermal blistering disease का मतलब क्या है? Which means that the cleavage or the breakage is happening at the level of the epidermis, right? So what are the examples? Anyone, if you are able to answer one, you'll be able to answer almost everything. The best way is, yeah, Barika says impetigo. Okay, Pemphigus, excellent. Anything else? Okay, impetigo. Since all of you are saying impetigo, I am also writing impetigo because it is superficial. It is within the epidermis. Perfect. Anything else? And in pemphigus itself, please elaborate this pemphigus, okay? Because it can be pemphigus vulgaris, it can be pemphigus foliaceus, it can be pemphigus, which other pemphigus? Vegetans, drug induced pemphigus, isn't it? All those things, drug induced pemphigus, etc. So all the pemphigus group of diseases, they come under intraepidermal blistering disease. Now what comes under subepidermal blistering disease? In subepidermal, which means below the epidermis, is the bulla which forms. The examples here, the first one should be a bullous pemphigoid. Everything else other than pemphigus comes here, like bullous pemphigoid, linear IgA disease, isn't it? Pemphigus, Pemphigoid gestationis, etc. So all those things are going to be subepidermal blistering diseases. Is that clear? So that is how we are going to divide this blistering disease. Either it can be within the epidermis or below the epidermis. Within the epidermis, सारे जो pemphigus है, you can give that as an example. Below the epidermis, anything other than pemphigus, जैसे bullous pemphigoid, pemphigoid gestationis, linear IgA disease, dermatitis herpetiformis, everything comes under subepidermal blistering diseases. Now, coming to the second part of the question, Describe Pemphigus vulgaris. Now, when you have to describe Pemphigus vulgaris, how do we describe? So, we have to go in the same logical method, right? So, what is our logical method that we used? First, we start with definition. So, in the definition of a Pemphigus vulgaris, the definition is Pemphigus vulgaris is an autoimmune. So it is actually an autoimmune disease. Okay? It is an autoimmune blistering disease caused due to, what is the cause? Caused due to the cleavage within the epidermis. Caused due to the cleavage within the epidermis. And यहाँ पे क्या होता है? The reason or the etiology is due to a desmosomal defect. See, all of you, when you are going to write down what is the reason for a pemphigus group of diseases, then here the reason is desmosomal defect. One moment. Desmosomal defect. Now, what happens in a desmosomal defect? The desmosomes, they usually attach the keratinocytes, right? So when there is a desmosomal defect, then the keratinocytes, they get separated from each other. This is what is happening in Pemphigus vulgaris. And here there is a defect of desmoglein 3 as well as desmoglein 1 defect, which happens in Pemphigus vulgaris. That is the reason for Pemphigus vulgaris. Now, after etiology, let us write down what are the clinical features. So, in the clinical features, the patient, because of desmoglein 3 defect followed by desmoglein 1 defect, the patient will develop oral mucosal erosions followed by flaccid bulla over the trunk in a middle-aged patient. This is the usual clinical presentation of Pemphigus vulgaris. Now, in Pemphigus vulgaris, you just need to remember one thing. These patients, along with these bullous lesions in the body, they will always have oral mucosal erosion. In fact, the disease begins in the oral mucosa. So when you see oral mucosal involvement, just say erosions, along with bullous lesions in the body, think about Pemphigus vulgaris. Think about Pemphigus vulgaris. Now, once you see such a patient who comes to you with the oral mucosal erosion and lesions in the body, bullous lesion in the body, you are definitely going to do some investigations, isn't it? To reach out to the diagnosis. What are the investigations that you can do? Anyone? Have you read about Pemphigus already? What investigations can you do? One investigation is a Zank smear. So when you do a Zank smear, what you can see is acantholytic cells or Zank cells can be seen. Acantholytic means, acantho means keratinocyte. Acantholytic, when the keratinocytes will get separated from each other, that is what we can call it as a acantholytic cells. That is one. What is the other investigation that we can do? That is a skin biopsy, isn't it? Skin biopsy and histopathological examination. So when we are going to do a histopathological examination, we can see a row of tombstone appearance. So what do you mean by a row of tombstone? The basal keratinocytes, they will appear something like this. Like in the graveyard, it's called as the row of tombstone appearance. And third one, which you should definitely write for your exam, is the DIF finding. So DIF means direct immunofluorescence. Okay, direct immunofluorescence. And this finding, the result, if you just write down for your exam, sure shot you're going to get marks for that, because here you can get a IgG and C3 deposits in a fishnet pattern or a chicken wire pattern in the epidermis. So that is what you can see in cases of a Pemphigus vulgaris, IgG and C3, and this is the magic word, okay? Like fishnet pattern, chicken wire pattern, row of tombstones, acantholytic cells. All these are very specific for Pemphigus vulgaris. And finally, we will also write down what is a treatment. A treatment, since we described Pemphigus vulgaris as an autoimmune disease, every autoimmune disease, the drug of choice is going to be steroids. So the management is going to be with steroids. Okay? So again, we have gone in the same method. Okay, this is what I would like to emphasize in this lecture. आपको पहले definition लिखना पड़ेगा, इसके बाद etiology लिखना पड़ेगा, फिर clinical features लिखना है, then diagnosis या फिर what are the investigations that you do to reach out a diagnosis, and then finally the treatment. So we are following the same order again and again. For every disease that you learn, please try to go in this format so that you go logically, isn't it? So that you're going to do logically. Of course, you can learn medicine. Anybody is welcome to learn medicine. You just need to follow your passion. Now let's see. Write a short note on Bullous Pemphigoid. अभी Bullous Pemphigoid कहाँ आ रहा था? Bullous Pemphigoid was coming under subepidermal blistering diseases, right? Subepidermal blistering diseases में. So let us see what happens, or how do you want to describe. So anybody who would like to give me assistance in writing a definition for Bullous Pemphigoid? Till now I was guiding you, right? So how about you writing one definition for Bullous Pemphigoid? Simple, based on whatever you know. So how can you start? Bullous Pemphigoid is a Bullous Pemphigoid is a what type of disease? Is it an infection? Is it a connective tissue disorder? Is it an autoimmune disease? Isn't it? So what is it? Sir, my doubt, please answer. So what is the doubt, Samantha? Flaccid bulla, is it that is what you are asking? See, flaccid bulla means which can break very easily. क्योंकि Pemphigus group of diseases में क्या होता है? The bulla is within the epidermis. काफी superficial है, right? So since it is very superficial, it can break very easily. Yes, थोड़ा difficult होगा when you start learning it for the first time, okay, especially with the terminologies and all, but then we don't have an option, है ना, तो ये सीखना ही पड़ेगा. Let's see, but it is not very difficult. Just go logically. Few words जो आपको याद रखना पड़ेगा, just try to memorize those words. ठीक है? So very good. So, Bullous pemphigoid is an autoimmune disease. Autoimmune disease means our body is attacking our own cells, isn't it? Which is predominantly seen in elderly patients due to subepidermal blistering. Due to subepidermal blistering. So this is what we call as pemphigoid, that is bullous pemphigoid. See, there is no meaning, it is just the name of the disease, bullous pemphigoid. Autoimmune disease है, usually seen in elderly patient, और यहाँ पे क्या होता है, सब epidermal blistering होता है, which means the patient is going to present to you with a tense bulla. So now let us write down what are the features. First one is the etiology. So यहाँ पे the etiology is in Pemphigus vulgaris. What was the etiology? Desmosomal defect, right? यहाँ पे it is hemidesmosomal defect. See, this hemidesmosomes, they also act like a gum or a glue which will attach the basal keratinocyte to the basement membrane zone. So when there is a defect of hemidesmosome, it can lead to bullous pemphigoid. And what are the examples? The examples are BPAG2 more than BPAG1. And what is BPAG1, BPAG2? It means bullous pemphigoid antigen. Okay, bullous pemphigoid antigen 2 defect followed by bullous pemphigoid antigen 1 defect. So this is what happens in bullous pemphigoid. Then how will the patient present to you? What are the clinical features in this patient? Clinical features is the patient presents with tense bulla in the trunk of a elderly patient. That is a usual presentation. अभी क्या है? Pemphigus vulgaris, we had a flaccid bulla, right? Along with flaccid bulla, we also had oral mucosal erosion. What was the age group? Middle age. यहाँ पे tense bulla in an elderly patient. That is about bullous pemphigoid, right? And how do you make a diagnosis, or what are the investigations? यहाँ पे the Zank smear is going to be negative. There will be no finding in a Zank smear because Zank smear can only see some superficial changes. Superficial मतलब within the epidermis. पर यहाँ पे where is the bulla? The bulla is underneath the epidermis, right? So easily it will be negative. But what about other things that can be done? We can definitely go for a skin biopsy and histopathological examination. In a skin biopsy and histopathological examination, again you can see IgG and C3, which is deposited linearly in the basement membrane zone or dermoepidermal junction. Okay, so the basic difference is पहले Pemphigus vulgaris was in the epidermis, chicken wire pattern या fishnet pattern था. अभी it is not in the epidermis, it is in the basement membrane zone और dermoepidermal junction, जहाँ पे आपको linear pattern दिख सकता है. The linear pattern, it is not a chicken wire pattern. ठीक है? So that is it about the skin. So sorry, this is not the skin biopsy. So we made a mistake here. It is not the skin biopsy. This is the DIF finding. Okay, DIF finding. Whereas in a skin biopsy and histopathological examination, here what do you see? A subepidermal split can be seen. A subepidermal split can be seen. Okay, so don't get confused. DIF वहाँ पे fishnet, यहाँ पे linear pattern, वहाँ पे epidermis, यहाँ पे you will see it in basement membrane zone. Whereas skin biopsy in Pemphigus vulgaris, we see a row of tombstone appearance. Here we see a subepidermal split. Clear? And the treatment here is going to be with steroids. The treatment here is going to be with steroids. How to differentiate from acne from a bulla? See, acne and bulla, let me just stop this discussion here. So here what you have to remember is, what is a vesicle? Vesicle means the diameter is less than 1 centimeter and it contains clear fluid. Whereas in vesiculobullous disease, what do you mean by a bulla? The difference with the bulla is the diameter is more than 1 centimeter and this also contains clear fluid. So whenever there is some lesion like this, which contains water, isn't it? Which contains water. If the diameter is small, we call it as a vesicle. The diameter is more than 1 centimeter, we call it as a bulla. And in acne, acne can present in different ways. Papule हो सकता है, not vesicle, pustule हो सकता है, nodules हो सकता है. So those are different types of presentation in acne vulgaris. Whereas usually you don't find a bulla, right? Don't find a bulla. Subepidermal split means, this word sub means below. Subepidermis means below the epidermis. Subcorneal means below the stratum corneum. So sub means below. Is that clear? Okay. So that is about the discussion today. So the key takeaway is of today's session is, whatever question that you may get, be it a short answer or a long answer, please try to go in the same methodology what we have discussed today to follow the definition, the etiology, the clinical features, the diagnosis, and then the management. So whenever you're going to go in such orderly fashion, the examiner is actually bound to give you marks, right? And making a definition and all, if you know the context of the disease, it is not going to be difficult. But yes, in dermatology, you will have to remember some new names, some new terminologies and all, which is again not going to be that difficult. You just have to give some patience and just some effort and you'll be able to do it. Yes, we'll also try to do psoriasis and acne as well. But please remember, in PW MedEd YouTube channel, you can definitely find an entire lecture for Farre Series, which was done last year on the same topic of acne and as well as vitiligo, eczema, as well as psoriasis. Okay, I wish all of you the very best. If there is anything that I can help you, please do let me know. I'll be more than happy to help. Wishing you all the very best for the final year exams, and we'll see you for the NEET PG preparations to clear all these things. Okay? In case of acne, there can be a clear fluid. No, in acne, we don't find vesicular lesion. There can be some pus within the lesion. Those are called as pustules. Okay? Is there any other queries you want me to answer? I'll be happy to stay back for some more time and to give you answers. If there is some difficult topics that you want me to discuss or anything. If not, then we will call it a day. Okay. So please try to explore the features in the MedEd app for more of these kind of lectures. Itching in the midline of the back. When you ask something that vague, it is very difficult to answer. We have to see what exactly is the presentation of the patient. Okay. So again, wishing you all the very best and take care. Thank you so much for being a very interactive crowd.